welcome back to Delicious Science. I am Dr. Joanna McMillan. I'm a nutrition scientist and dietitian, and this is my podcast where basically I try to cut through some of that noise and some of the nonsense that's out there and give you the true evidence-based science of what we're talking about. Now, today, this episode is a little bit different from what I normally do, and it's because last week I posted a reel on Instagram and I wasn't sure how it would land because it wasn't a recipe. It wasn't actually around the nutrition science. It wasn't a nutrition tip. It was just me being direct about something that's been sitting with me because of the conversations I'm having with friends, with colleagues, with family, and with the women around me in particular. And what happened was that I got over 40,000 views on this topic. The comments kept coming too. It was performing much better than many of my other reels. And I realized that I had touched a nerve and that this is a conversation that deserved a little bit more than simply a 60-second reel. So I thought, let's dedicate a whole podcast episode to this and let's go a little bit deeper. I want to say upfront what I said in the reel and what I said in our very first episode on GLP-1 drugs. So I'm talking here about semaglutide, tirzepatide, and the other drugs in this class. They can genuinely be transformative for people living with obesity, with type 2 diabetes, and with other serious metabolic health conditions. The science supporting their use in these populations is real, and in many cases, it's truly remarkable. That is not in question, and it's not what this episode is about. What I want to talk about in this episode is the part of the story that rarely makes it into the headlines, but it is making it into conversations across the country and around the globe. And that's this: the growing use of these medications in people who are already at a healthy weight. The gap between what the science actually shows and the way that these drugs are being talked about in everyday conversations. And the question that I keep coming back to: are we as a society using a powerful medical tool to bring diet culture back through the front door? If you missed our first episode on GLP-1 drugs, I'd suggest that you go back and listen to that one first, because that's where I covered the mechanisms, the nutritional risks, the gut side effects, and how to protect your health if you are taking these medications for legitimate clinical reasons. So I'm not going to cover that stuff today. This episode is about building on that foundation. So let's get into it. The reel and why it resonated. The video I posted was really quite simple. It said, these are medical treatments for medical conditions, and they were never designed as a quick cosmetic reset. And we're watching them become exactly that. The comments and messages that I've received are telling me that I've touched something very real here. All sorts of stories describing women feeling under pressure to take these meds, friends advising them to take them just to drop a few kilos and then come off the drug. Other women feeling like they're suddenly the biggest person in their gym class or the biggest person in the room because they're the ones not taking the medications. So I think that it's really important that we have these discussions and that we can compartmentalize where these drugs are being used appropriately and where they might be adding to a completely different problem. So I've also had women who tell me that I'm wrong, that what's wrong with these medications? What's wrong with using something to help us to control how much we're eating, to help us to be thinner? Am I old-fashioned? Don't I understand how debilitating it is to live in a body that doesn't fit with cultural expectations? So I hear that too. I understand it. I work in media and have done for most of my life. So I well understand those kind of pressures to conform to a certain beauty or even what people perceive as being the healthy ideal. So I don't want to dismiss any of that. And I think it's really important that we start having these discussions. Caring about that pressure is exactly why I think we need to talk about this in a very, very clear way. So what I'm seeing is a very specific pattern. This is healthy weight women. So I'm not talking here about people with obesity, nor people with metabolic disease, who are using these medications to become smaller than they already are. Sometimes on the advice of a prescriber, sometimes sourced without a prescription at all. And the framing around it is very, very casual. I just want to lose a few kilos before summer. It's helping me stay on the straight and narrow. I've been taking it for 3 months and it's been great. You should try it too. And actually, it's this casualness that concerns me. Not because I think any of these women are being foolish. We all make our own decisions about what it is that we want to do, but because they're responding to pressure, responding to a pressure that our culture's created, and that medicine is now handing them a tool to manage, because the drug doesn't care whether the person taking it needed to lose weight, and the consequences are not waiting for permission. So what does the research actually show, and what does it not show? Let me be very precise here, because precision matters. We do have landmark trials on semaglutide and tirzepatide, which is not yet approved in Australia yet, but these trials have been done. So we've got the STEP trials, there's SURMOUNT trials. These enrolled people with obesity, defined as a BMI of 30 or above, or people with a BMI above 27 with at least one weight-related health condition, like high blood pressure, type 2 diabetes, or heart disease. So those are the people that the drugs were tested on, and they're the people that the approvals for the drug were granted on. In these trials, the impressive cardiovascular outcomes, so things like the reduction in heart attack and stroke risk that you might have seen reported in the media, those are coming, and sorry to reiterate this, but it's so important. These are from trials specifically in people with pre-existing cardiovascular disease risk and obesity. The potential dementia protective effects are still emerging. And again, they're studied in people with metabolic disease. So you cannot take these findings and apply them to a 55-year-old woman at a healthy weight who simply wants to fit back into her old jeans. The science simply does not support that extrapolation. And yet, the use of these drugs in healthy weight people is growing very quickly. For example, data from Denmark, which has particularly good national health records, well, they found that people starting semaglutide without a type 2 diabetes diagnosis rose from 1% of all new prescriptions in 2018 to 33% by 2022. That's a dramatic shift in who's actually taking the medications, and it's happened faster than the research can possibly keep up with. We simply don't have safety data in healthy weight people on these drugs. We don't know what happens to their cardiovascular system, their hormonal health, their bone density, their gut microbiome, their mental health over 5, 10, 20 years. This is not a theoretical gap, it's a real and significant unknown. When people ask me, is it safe for me to take this just to lose a little bit of weight? Well, the honest answer is we don't know. The muscle problem, especially for midlife women. Here's the piece of the story I think is most underreported, and it concerns me most from a nutritional and a long-term health standpoint. In the clinical trials on these medications, roughly 25 to 40% of the weight lost was lean mass. That's muscle and bone, not just fat. Now, in someone with significant excess body fat to lose, that proportion is concerning enough. Although in those populations, normally there's some excess lean mass as well as that excess fat. But it's why we stress protein and resistance training heavily if you're on these medications for clinical reasons. But here's the thing. In a person who's already at a healthy weight, there is much less excess fat to lose, which means that the weight being lost when someone at a healthy weight takes these drugs is likely to come disproportionately from muscle and bone. Think about what that means for a moment. You take a drug to become thinner, you achieve that, but what you've actually done is lost muscle, the tissue responsible for your strength, for your metabolic rate, for your balance, your physical independence as you age. And muscle is also the chief organ taking glucose out of the blood, so helping you with your blood glucose control. For midlife women, this is particularly serious. We're already navigating the muscle and bone changes that come with perimenopause and menopause. Estrogen plays a major role in maintaining both, and its decline accelerates loss of lean mass and bone density. Everything we know about healthy aging for women says protect your muscle, build your bone, prioritize strength. So taking a medication that accelerates muscle loss in an already lean person is moving in precisely the wrong direction. And then there's the fiber question. When overall food intake drops dramatically, as it typically does on these medications, fiber intake usually drops along with it. Now, the gut microbiome depends on a diverse range of plant fibers to thrive, and less fiber means less microbial diversity, less production of the short-chain fatty acids that our gut and our immune system depend on, and often changes in gut transit that can be quite uncomfortable. I talked about all this in our first episode, but I want to name it again here in the context of people who are already eating healthily. Even a healthy diet can become nutritionally inadequate if you're only eating very small amounts of it. What the drugs do in the brain and why this matters more than we realize. Now let's talk about something that wasn't part of that first episode, because the science has evolved and patient reports are becoming harder to ignore. GLP-1 receptors are not just in the gut. They're distributed throughout the brain, including in the area that makes up what we call the reward system. Specifically, the nucleus accumbens and the ventral tegmental area, which are the core structures of the mesolimbic dopamine pathway. This is the system involved in motivation, pleasure, and the drive to seek rewarding experiences. The mechanism that silences food noise, that's the constant preoccupation with eating, hunger, and cravings that some people with obesity experience, well, it works partly through modulating dopamine signaling in this reward circuitry. That is in part why these drugs are effective. But there is a question that is only now being taken seriously. Does that reward blunting stay specific to food? An increasing number of people taking GLP-1 drugs are reporting something beyond appetite suppression. They describe a broader flattening of emotional experience. So less excitement, less motivation, and less joy. Reduced interest in hobbies, in social activities, in connection. Still knowing intellectually that good things are happening, but somehow feeling less connected to them, less moved by them. The clinical term for this is anhedonia, and there's now a growing body of patient reports describing exactly this phenomenon. Some people are calling it Ozempic personality. Now, this is important. We don't yet have robust clinical trial data specifically measuring anhedonia in GLP-1 users. The psychiatric assessments used in the major trials rely on questionnaires like the PHQ-9, which is a depression screening tool. It's not designed to detect motivation loss or hedonic blunting as distinct phenomena. So the question has essentially not been properly asked. What we do have is a mechanistic reason to take these reports seriously. And we have an emerging body of evidence suggesting that in people with obesity, who may have abnormally hyperreactive food reward signaling, GLP-1 drugs appear to normalize that system. Now, that's likely therapeutic. But in a person with a healthy weight and normal dopamine function, the same modulation of the reward pathway could dampen what was never excessive: normal motivation, normal excitement about life, normal joy. 2025 paper examining GLP-1 drugs and reward circuitry concluded that effects appear selective to reward-related processing and may normalize hyperreactivity in the context of obesity. But it explicitly noted that this may not apply to people without that underlying abnormality. I want to be careful here not to overstate what we know. These are signals, not settled science, but they are signals in a population, healthy weight, off-label users, where we have no trial data at all, and they're mechanistically plausible in a way that demands that we take them seriously. When someone tells you that they've lost their motivation, their enthusiasm, their interest in the things that they used to love, and they happen to be taking a drug that modulates the brain's reward circuitry, that is not nothing. The peer recommendation problem. Now, I want to spend a moment on something that struck me again and again in the comments on that reel and in the conversations I'm having with the women around me, and that is the peer recommendation effect. Women are advising other women to take these medications, not in a clinical setting, not after a medical assessment, over coffee, in group chats, in the comments section. Just try it for a few months. My friend lost 8 kilos and she loved it. I got mine through whatever online platform and it arrived in 2 days. One woman even told me she can get it delivered to her letterbox. There are several problems with this. First of all, these are prescription medications. In Australia, they require a prescription for good reason. They require an assessment of whether the benefits outweigh the risks for a specific individual with specific health circumstances, and the access route matters. Second, the social contagion effect in this space is real. Weight loss is always spread socially. When the method changes from a fad diet to a pharmaceutical, the social contagion dynamic doesn't disappear. It attaches itself to the new tool. And this is how a medical treatment suddenly becomes a trend. Third, and this is the piece that sits most uneasily with me, the casualness of the advice obscures the serious questions. Nobody in these conversations is asking, what proportion of the weight you lose will come from muscle? What happens to your microbiome? What does this do to our reward system over time? What happens when you stop? The conversation is skipping straight to outcomes, the kilos lost, the dress sizes down, and it's missing the mechanism entirely. The bigger question, diet culture with a prescription pad. I ended my reel with this. We fought hard to move beyond diet culture. We should be very careful that powerful new medicines don't take us straight back there. I believe that, and I want to say more about it. Diet culture is at its core the idea that thinness is the same thing as health, that the body you have is a problem to be managed, that shrinking yourself is a virtue, and that any cost to your relationship with food, to your enjoyment of eating, to your strength, to your mental health, is worth paying if the number on the scale goes down. We spent years, decades, building the body positive movement, the intuitive eating movement, the health at every size framework. Not because those frameworks are without criticism, they're not, and the science of weight and health is genuinely complex, but because they pushed back against the enormous harm that diet culture inflicts, particularly on women and girls. And now we have a drug that is for many people medically necessary and genuinely beneficial. And we're watching it be absorbed into diet culture's logic, into the idea that you should be thinner, that thinner is better, that a medical shortcut to thinness is something that every woman should at least consider. What does it say about a cultural moment that powerful appetite-suppressing drugs are becoming casual social recommendations amongst women who are not medically overweight? What does it say that we now have a drug that can make women want to eat less, care less about food, feel less, and some are describing this as a benefit? I'm not interested in moralizing here. I'm not telling anyone what choices to make about their own body. But I am asking us to be clear-eyed about the forces that are shaping those choices. And I am asking the medical profession, the pharmaceutical industry, and regulators to hold the line on what these drugs are treatments for. They are treatments for a medical condition, not tools for conforming to shrinking beauty ideals. What to do with all of this? If you're taking a GLP-1 medication for a legitimate clinical reason, obesity, type 2 diabetes, significant cardiovascular risk, this episode is not directed at you, and I don't want you to come away from it feeling judged. Our first episode covers what you need to know about protecting your nutrition while on these drugs, prioritizing protein, fiber, calcium, vitamin D, resistance training, and that guidance stands. If you're considering these medications for weight loss and you are already at a healthy weight, I would ask you to sit with a few questions. What is your actual goal? Is it better health, more energy, more strength? Or is it a number on the scale or a look in the mirror or fitting into something smaller? Because if it's the latter, I gently invite you to examine where that goal is coming from and whether a pharmaceutical is the right path to it. What would it actually mean to feel strong and well in your body right now? Not thinner, well, energized, capable, mobile. What would it take to build that rather than to shrink to it? And if you're experiencing a subtle flattening of joy, of motivation, of interest in the things that you used to love, please name it. Talk to your doctor about it because it is worth taking seriously. Okay, so I want to close with something that I said in the reel that I think is worth sitting with. If being thin starts to matter more than feeling strong, eating well, exercising, enjoying dinner with friends, and participating fully in life, is it really health? These medications are medical treatments. In the right context, for the right people, they are remarkable. The science of metabolic health that underpins them is genuinely exciting, and there's much more to come. But a medical treatment deployed in the service of diet culture does not become diet culture free. It just gives diet culture a prescription pad. We deserve better than that. And I think if we're honest, we know it. Thank you so much for listening to Delicious Science. If this episode made you think or made you want to share it with someone, please do. Leave a review if you have a moment. Follow the show, of course, so that you know when I have new episodes coming out. And all of that genuinely helps others to find the show and helps me to build it. I am Dr. Joanna McMillan, and I'll see you in the next episode.